And also, I would just mention that for right now, our meeting will just be an informational only meeting. We're waiting for one more board member to arrive, at which point we'll have a quorum and we can go back and vote on the things we need to vote on. The last thing is, this is a little unusual. It's only the second time it's happened in my tenure, but both our chair and our vice chair were unable to attend today. And so what our operating procedures say is that the board members present will elect a moderator for this meeting. And so I would entertain a motion for someone to nominate a moderator for today's meeting.
Would like to nominate Greg.
Second.
Second. Any discussion?
He knows what he's doing.
Yes, he does. Any discussion? All right, all in favor say aye.
Aye.
Any opposed? All right.
Thank
Moderator.
you. So we'll proceed, and when we get the quorum, we'll go back and do all our formalities and voting, and Johnny just walked in the door. Well,
There we
Johnny,
go. Our quorum is.
so while we go ahead with the quorum, Johnny, be prepared to vote back there. Bill play. So Tony has called the meeting to order. So the next item, we don't need to vote to call the meeting. Do we?
Yes.
We just need to review and take action on the board agenda as you have in front of you. In accordance with the State Government Ethics Act, it is the duty of every board member to avoid both conflicts and interests and appearance of conflict. If anyone does have a conflict, please identify yourself now. And if not, do I have a motion to approve today's board agenda?
So moved.
Thank you. Second. Steve. So next item of business is to.
We got to.
Oh, we got to vote and never get the stuff right. So let's have a vote.
Who nominated this guy?
All four? Any against? Okay. Next item, review and action of the September board meeting minutes. So you have those in front of you. If you have a chance to already review them, fine. If you need a second to look at them, go ahead. And then I'll set a motion to approve them.
Is it just to approve the agenda? Or
This
what-
is last month's board meeting.
Okay.
Thank you. First, second. First and second, so board meeting minutes are approved. Gotta vote. It's a three-step process. All four? Any against? Okay, thanks. Presentation and updates. Lee, are you prepared to provide the fiscal report? Thank you.
Hello. I'm the new HHS business officer. I've been enrolled for about 2 months now. So I'm assuming the presentation is on video. And I'll minimize that and it should be open at the bottom for you.
While Lee gets ready, I would like to take a minute just to introduce Lee, since this is our first in-person meeting since she was hired. So for those of you who remember, Lisa White was our former business officer. She left us back sort of late spring, early summer to actually go work for a nonprofit. So she's still benefiting our community. And we did a pretty exhaustive search, had a really highly qualified applicant pool, and we're very pleased to promote Lee. She was already in the business division. She was our facilities and operations manager, which has a long history in HHS finance. And I must confess, she is doing a fantastic job. So we're very glad to have Lee.
So as you know, we've wrapped up our fiscal 23 year. And just an overview of where we landed at the end of the year. With the social services, pretty much a lot of the difference in our monies was each meeting, that we didn't give out all of our direct assistance dollars. That's why it looks like overall we're at 93% when really we were higher up. But, with that, salaries and benefits, revenues came in at 95%. Then overall revenues, 99% brought in. And then again, it's in the social work and admin where we had like a lot of lap salaries and the positions empty. So that's what made us not be quite at 100% like we'd like to be. Expenditures by ledger. So overall for all of HHS, as you can see, didn't spend it. We were only 70% charges and fees. Thanks to repairs at 85% of everything else. Further support again, that's some of our foster care dollars and that we were able to draw down. And again, the direct assistance with emergency assistance stuff. So here you see that 76%. So didn't spend all of our foster care board, special assistance was 98%, SIP was spent 46%, and then low income 41% spent, and adoption assistance 9%.
So does that mean money was left on the table with low income energy or assistance?
Yes. This money we had budgeted and then it did not get spent. We did not give it out. Provided. Or to our citizens.
Were people being, can I just ask one, were people being rejected, or do you know why it wasn't spent, or did you over budget, or it's just not that time of the year?
It just, the money wasn't given out. Bill might be able to speak better to that with some of the crisis intervention programs that we've given out. But of the money that we had budgeted, that's what we gave out. So not sure that it was.
Some of this on that particular issue, some of this I might cover a little bit in my director's report.
Okay,
Philip might want to speak to it as well. And some of these things, if you look at them like foster care boards. So we project at the beginning of the year what we think we will need in foster care expenses. But as the year goes on, obviously, when you're projecting in January for a fiscal year that starts 6 months later in July. So we really don't, I mean, there's no way to predict how many children are going to come into care, how expensive the placements they are in are going to be. So that's probably a good thing on the foster care. You know, if we're underspending there, that's actually a good thing. On the crisis intervention, low income water assistance, we were spending those funds through our contractor last year. So it could be that enough people that apply, it could be other things. We'll talk about that later. But Phil, do you want to comment on
Yeah,
that?
there was a backlog to some extent with the crisis program. And we also, the other piece that drives some of that is emergency rental assistance that we've been administering for the last 3 years or so. I mean, because in essence, a lot of the people who would normally apply for crisis probably might not have been eligible because the limit for crisis is $600 to help someone out. We saw lots of power bills, $2,000 and $3,000 and $4,000. And what the crisis policy says is that $600 won't alleviate the problem, then you have to deny the crisis act. So they don't give the $600. And there's just, we had one individual who owed $11,000. You know, but we could serve them with the emergency assistance dollars. With the water assistance program, those were federal dollars, one-time only dollars we had for about 3 years. We paid everybody's water bill who applied. It just that we had more money than we could spend.
and whose rule is it about the $600?
That is a state rule. It actually, this board pushed forward to change that amount to 1,000. The General Assembly actually changed the amount to 1,000. We've not gotten the Department of Health and Human Services at a state level to change their amount from 600 to 1,000. Every time I bring it up, they say you can serve less people. Well, that's a double edged. I mean, I serve a lot less people at times when I deny them and can't give them the 600 because They owe 1,200.
Back to these numbers. On my personal list, continue to advocate for this. So I understand the legislature has approved the limit up. So we could go all the way up to 1,000, but the department has not written it into policy, so counties aren't allowed to. It's not a requirement in the legislature, it's just allowable. So I do understand the department's rationale that if you give more assistance without any more dollars, you might serve less people. I think, though, I would like to see the department run some data metrics, because we know every year that we're not the only county that returns some of its money. So it might be that the state could raise that limit. Let's say we started with $700, and then we see, because it might be that we could actually serve it. Bunko last year, we probably could have served the same number of people and just help them more. So I just want you to know that I have that on my personal advocacy agenda, because this board was very strong and wrote a very strong letter to make it happen, and it has happened. Now we're just working through it from a policy perspective and the data perspective.
Phil, that doesn't eliminate the need.
I know, I don't disagree with that. As Tony says.
If they can get the $600, that will lessen the amount that they owe.
Right.
Yeah, who makes that decision that 600 is not going to make a difference to somebody? That's
It's just mine.
Statement to whether or not they have means to pay the rest of it. I mean, basically, so we accept their statement, but bottom line, if somebody owns $2,000 and they have no discernible income, it's kind of hard to say they have the ability to pay the other 1,400.
But is that an assessment that you take at that particular time? Because that $600 might keep their lights on.
Yeah, I don't disagree.
They say if you just pay that, we'll work with you, but I hear you.
Yeah.
It is, it would be helpful to raise the limit to 1,000. There's money that is returned, especially for the large counties. I will tell you, small counties burn through their money because they don't have other resources. They'll burn through their money in a heartbeat. The larger counties, because most larger counties have other resources within their communities, tend to not spend all of it.
The other thing we can do, Johnny, and we do this, is like, we also have a network of other community assistance for nonprofits. So if someone comes in and their light bill's $1,000, and the only way their lights will not get cut off is if they can come up with $1,000. Well, it might be that this crisis intervention program puts 600, and then we partner with other community partners like charities, ABCCM, Swanville Christian Ministries, and the nonprofit agency will meet the balance. And so it's really like a coordinated community effort. And Philip's right, the smaller, if you're in a very small under-resourced county, you may not have that level of nonprofits. But still, to the point, if we raise this up to 700, that will be another $100 that our nonprofits could keep to help with other things that these programs don't touch. So unless the board, I'm continuing to raise the mantle for the board. And I've had one conversation with the assistant secretary about this. I plan to have another one. I'll be glad to report back to you on what progress that we can make.
I mean, I think this is a really important issue that we should not let just go from this just meeting, because $3 million, we know for a fact, there's $3 million of need out there, at least, right? And so our systems are not designed right to meet the need of our neighbors and our community members. And so I think we got to fix that. And it's great that, I mean, what you're saying, that there is a coordinated effort among the other nonprofits right now in place that does happen. Just from personal experience recently, we're at the ABCCM Free Clinic, we're screening people now more regularly for these types of issues. And the number one issue that people need is food. The second is energy assistance. And so they are being sent to ABCCM, or they're being sent to St. Vincent de Paul. And all of those systems are stressed. they're stressed. And so when I see $3 million in our community, that's the number one need that we're seeing every day. It doesn't make sense to me.
I know that if they're receiving money back because we haven't paid for it, it implies that there's no need for assistance.
Exactly.
Right.
And they shouldn't be taking money back with that assumption. I mean, if they have through federal and state taxes and what have you, given that money for assistance, they should be asking themselves, why are we taking it back?
Really?
Because that is $3 million of assistance that someone didn't receive, but it's going back to what? The state.
Yeah.
For what?
Who knows?
It actually is redistributed back out to counties in the next fiscal year is what they generally do.
Well, that's kind of paying
they
it forward
pay.
for next year's budget, having not spent it in this past.
Or they use it and do supplements. What they've done over the last few years is they'll do supplements for people who have already gotten everybody who got an energy assistance payment this year right now is gonna get a supplement to that payment from last year's money that was left over.
Got $11,000.
Whether they need it or not.
We can pay this.
But
Yeah.
it just goes to offset the cost of their bills.
Well, it gives bureaucracy a bad name.
Yeah,
I mean, the bureaucracy is there to help administer things, but then at the same time, they're interfering with the ability to, provide the assistance.
I wish there wasn't a limit. I mean, it would be easier to administer the program if you didn't have it. Yeah, that would just make it much easier, how much do you need within reason kind of thing, so that you can serve as many people as possible. But there isn't.
Well, the problem is, you're playing judge and jury to a certain degree. When I'm coming up asking you for assistance, I don't have any current. And you go through my personal file to see whether or not I
Well,
qualify, and I have no lights, no heat.
We served a lot of people with ERA, I'll tell you. Those people who the $600 wouldn't offset, they got referred to us and we did, utility assistance to the rental assistance program. So I'm not saying, a lot of those people got served a lot of ways, other than maybe through crisis. We just left a lot of crisis money on the table, but that ERA dollars are starting to run out. And probably won't last us through the spring of next year, somewhere in that neighborhood. So that kind of gravy train is starting to go away. Yeah, Jack.
I'm just curious, how do you get $11,000 power bill? I mean, that's sort of like, that's inconceivable to me. So is it like over 4 or 5 years? Is it from, I don't understand.
I don't either, there was a moratorium for 2 years.
Oh, who had COVID?
Yeah, that they couldn't disconnect people for like 2 years and people ran up big power bills. And it's kind of funny about Duke Power. I don't know what their criteria is, but once they started disconnecting, some people they disconnected and some they didn't.
Okay, because I don't know if I've had $11,000.
So if I could switch gears to the other part of the budget that was not spent, and that was in social work. And I'm just curious, one of the things that we've talked about is we know there's a lot of vacancies, it's hard to recruit, there's a workforce shortage. And that's where this is coming from largely, if I understand it correctly. And so knowing that will continue, that's a difficult thing. There's a plan in place to actually use the budgeted money to actually pay the current people. And, in a higher wage category to make it a more competitive and sustainable position for the people that we have. Use the money we have to actually pay the people we have at a higher salary in order to sustain that workforce and hopefully recruit better in the future.
We are currently paying a stipend to our child protective services assessment staff. That's where our huge turnover was. We got down to, I think, under 55% capacity of our staff.
Yeah.
So the commissioners did allow us to reinvest some of those dollars, and they're working a lot, we're paying them a stipend each pay period until we can get back fully staffed. So we actually have employed that strategy where our largest turnover is. And it does seem to be helping some. I mean, there's still, really, it's a supply and demand issue for qualified social workers to do child welfare. But we have increased our recruitment strategies. We're using more innovative strategies. Vic McGuire training, we're able to put out an amazing, I sent it to you guys, amazing social media advertisements. And so we're working really hard on that. And we right now are paying more as a supplement for folks who are working.
Do we know currently right now where the salary range lies as comparative? You know, like where are we in the competitive range? Are we at the 50th percentile, the per market? And, you know, like, it seems like in this, if we have the money, we would probably want to be more like in the 80th percentile, not in the 50th percentile, you know, like really make this really, yeah.
We felt like that was part of the problem, is that we were in the midst of a 2-year compensation study for Bunker County. And when we finished our compensation study, as the world was spinning, what happened is we finished it. Our data was 2 years old when we finished it. Well, we started it pre-COVID. So by the time we finished it and implemented a new salary structure, the rest of the world had raised their salaries tremendously in this area. So we really were no longer competitive. We used to pay, honestly, some of the best set wages in the state of North Carolina for our social work, really all of our staff. And now we were down in the middle of the state. So we dropped down to about the 50th percentile. And you add on top of that the enormous cost of living here. So we're having a hard time attracting social workers, especially social workers right out of college with school debt, who come and live in Nashville and make less than they can make in the 2 counties over. So that was why we did this study, and we raised our wages. My understanding is we're going to do a market analysis on these positions effective January. So that's what I've been told by the HR department. So we're actually going to kind of look at our current situation against the market so that we can be current with that.
Yeah.
Also, I think our commissioners were very gracious and provided, they sort of got us back in line with our cost of living adjustment last year, and that's helped somewhat. We're still not at our target capacity to stop paying that stipend. So while it's getting better, we're really not there, but we have seen some improvement. Rebecca, I'll let you weigh in because you live this every day and I'm looking at it occasionally.
Yeah, so I would say we started to make some improvement right after the commissioners approved the allowance is what we're calling it. It's an extra $200 per pay period for CPS investigators. We did see some improvement. I think the improvement mostly came because we opened up the qualifications to non-social work degrees. And so we saw kind of a lot of folks coming in. We're still seeing some of that. Unfortunately, we have had some additional resignations since then. So we had gotten down to like 3 vacancies with a lot of people in training. But we're back up to about 10 vacancies now with a lot of people in training. And so it's still really strained and challenging. I think my understanding, I don't have a clear understanding of whether or not there will be a compensation change anytime soon. I think they are looking at a market analysis, but that's not an immediate help or support. And I personally don't know when that would be implemented, if there would be a change made. So that's still a concern for me that I'm trying to navigate and figure out what is the longer term solution to this, because it does continue to be extremely challenging.
I think not my job to, but I would put this out here as a thought, is once that market analysis comes back, if we are not competitive, then it might be an action this board would want to consider to advocate with decision makers
What's
that
the
we are
timing of that?
Because you will not get best in class workforce unless you're paying best in class wages. We do have an incredible child welfare practice model here. And I do think people like to come work for us. But again, you know, your rent literally, you can literally live in the county next door and your rent is half what it will be here. And I've had a county market their position. They were hiring a human service position, it wasn't, and they were saying, come live here and eat and play in Buncombe County, and you will have more money in your pocket. That was their advertisement for their position. And I thought, wow, brilliant on their part, and we really need to pay attention to that. So I think that we need to wait for the market analysis, but at that point, if we are not near the top in North Carolina because our cost of living is near the top, then I would hope this board would consider advocating on behalf of our staff.
When does this happening, this market analysis? When is the market analysis happening?
My understanding is in January, it is the last I heard, but it'll have to go before commissioners. But that's that's the date that I heard in this meeting.
Is
So
there
I
any-
can't speak definitively, but I understand in January.
Is there anything that we can do to support you that the market analysis actually happens?
I mean, I don't know what that would look like. I guess my confusion is that as part of going to the commissioners, it was something that was said would happen. But I haven't seen like action steps since then, so I'm not sure with where we're at.
I think again, we talk about this in board orientation, it's like, I think because this board is an appointed board of the county commission, and I think your advocacy is usually with your appointing authority, which is we with commissioners, you know, and we do have a commissioner on our board, unfortunately, she's not here today. So I think ultimately this is a county commission decision, and you are an extension of that commission. I mean, you are appointed to oversee, make sure the HHS is resourced, effective, and efficient. So I think the advocacy is just simply the
Yeah, it's just if we're talking about a market analysis happening and then we're gonna do something after the market analysis happens, I want the market analysis to happen. I'm also.
We would welcome any influence you may have. I mean, we would certainly welcome that.
Yeah, I just want us to have all the correct information. I don't want us to be operating off of, oh, this is gonna happen, rainbows and butterflies.
And let us know what we can do. We can make some calls. Find some mental health assistance to help you through this. But I know, I'm serious. I know I don't know personally, I'm making an assumption that your job is just tremendously stressful. And I think through this whole process of learning your staff, some level of intervention needs to be to give strength through the process while this is happening. I don't know how that happens, but I just know mental health is so important, and that's what your clients are dealing with, but the people dealing with the clients need it as well. And so I want to make sure that if there's anything that we can do, because I've talked to some of your social workers, just the ones I know, and they're trying to find affordable mental health care for themselves to give them strength to get through this.
That's accurate. I know that the county is kind of piloting some strategies with another department around some access to clinical services. I think we've done a good job internally around support. So we have access to a resiliency coordination model, you know, some of that, but it's not clinical intervention. And I do know, I would venture a guess, I do not know this for a fact, that 50 to 75% of the people that work for us go to therapy, like some type of course, because it just is that type of stressful work that is done. And so it has been, you know, suggested that we access someone that's more clinical that can come in and support. And it's something that we've talked about, like strategies around.
Need it. Just what I see on the news, and I know I don't see it internally, and I know we're behind in our schedule, but what I see makes me sad just from the TV, and I know I'm not internally, but I see it. And I know it from some of the other committees and boards that I'm on. And it is. Well, I'm on the jury, I'm on the grand jury. So some of those come through there. And I know it's coming through here. And we have to stop what we're doing. Because it's just too traumatic. And you don't get to stop. That's all I say.
Well, before we turn it back to the league for her to finish on the fiscal report, one thing that Jacqueline brings up is keeping our eyes and ears and open as means of recognizing that those within our agency that are in highly stressful jobs, while there's solutions to hopefully fill vacancies, increase pay and things like that, they're also being exposed to a daily level of stress that for any given individual is hard to manage. And just like there are on the spot people there for fire and rescue in terms of helping them with their support, you know, so also maybe our social system is also being exposed to a high level of stress. So maybe some inventive ways to say, how can we support what we have while we're trying to build what we need? One last point is there a reasonable action point we can take as a result of our discussion about the 41%? I know that's complicated as well, but is there something that we can say, well, as a result of this, this is something we can do, or this is a conversation I can have, or
On those two particular.
on the 41%, yeah, low income.
Yeah, that honestly will kind of resolve when I do my director's report.
Okay.
Way to there. On the other ones, honestly, like I said, 98% is not bad. The 86% you could see almost as a victory because, you know, if we spend less on foster care, that's probably. Adoption assistance also is almost 100. So really, it's just where this would jump out at me is you only spent less than half of these funds, but I'll.
We'll get to that a little bit later. Okay.
We'll have a different approach this year.
Okay. Lee?
Sorry.
That's hijacked my meeting. So, public, they have anticipated more revenue. They've gotten a lot of, grant dollars and different items to help boost their system. So they're all doing pretty good. Making their budgets. Vacancies again for salaries is the biggest thing, but. Yeah, I was 82%, so. But all the others, I think they were pretty good in line because they had additional revenue that helped. Vet and animal services, 99%. And then Stoney also wanted me to go over because right now we're beginning we've already started the FY25. So it's like, you know, we're planning now what we're going to need in a year and a half, which is sometimes hard to figure out because you don't know what's going to happen. A lot of times we may have had extra dollars that we thought we were going to need a year and a half ago, but that's where some of that changes. But so far we have the IT request, anything that's over $5,000, that deadline is already passed. That was September 22nd. We submitted, I believe, 2 items. Security system that we're wanting to have here at 40 Cox, and then for a program for our language assistance team. Personal requests are due today, so we're asking a big ask on positions. Right now we're asking for 44.5. A lot of those, probably 25 to 30 are currently grant positions. So like your mobile team, our neutral facilitators, visitation coaches that are currently contracted out, they were just working positions. So that's where a lot of that's coming from. Then we got our vehicle requests due here and our capital projects due next month. And then it starts getting into, I'm having my staff work with each of the directors on building their budgets, and hopefully we'll have that all done internally by December 1st. So we can go back and review and then we'll be in presenting to the assistant county managers in January. And then they're having the budget congress is what they call it. That's in March. So
One thing
Just a real quick question, remind us, what is the fiscal year that we're on?
July to June.
July to June. Okay.
One thing I'd like to do for this year is, most years I wait until the budget submission is completed and then I bring it to the board. But this year, I think I'd like to keep you updated as we go so that you understand it's a lot to give you at one time. So like, for instance, that personnel request is due today. That's the personnel request for next July 1. And it does look large, but there's three high priorities for HHS that really must happen next year. And it looks like a lot of positions, but actually all these people are already working for Buncombe County as contractors or are in a grant fund. So those three things will be our public health mobile team. And we've educated you guys on that as we've gone. And we're hoping our actual mobile clinic will be here soon. But this is a team that actually provides core public health in the community. And I would say probably is one of the best strategies we've implemented from an equity perspective. And I get people from the community thanking me for this mobile team on a regular basis. So if I go out to community events, I'll have people come up and say, thank you so much for that mobile team. Or I'll go to a community event and there they are. So I think that it's imperative this year that we take those staff out of a grant fund because it's core public health and we move them over into the HHS budget. And there's never going to be a better year to do it because one of my contract partners is going to realize at least $1 million in additional revenue due to Medicaid expansion. So I will now have $1 million already in my budget. I would not have to ask, and what I would like to do is reinvest it in this global health team. And I'll have money left over, by the way. So they will be budget neutral. It strengthens our core public health, and it really does promote an equitable approach to public health where we're going to the community. We're not asking the community to come to us. The second thing is going to be this energy assistance program that I'll talk about here in a minute, but I may go ahead and talk about it now. We'll just take it off there. So I sent you guys a letter. We contracted out our energy assistance programs for 20 years. And our partner has been amazing. Just to give you the history, way back, we actually contracted out to 3 local community partners. And then the state of North Carolina made the decision probably, what was it, Phil, 10 years ago, to move that program into NC Fast, which is the state eligibility system. And has high security. And that system is not really open to letting contractors into it. They really like everyone in that system that is providing eligibility to be a local county employee, a means tested employee. But we were able to keep doing it and our partner kept going with NC Fast. But over the years, several things happened all together. And last year it all culminated for them. The workload increased. Their ability to staff decreased like the rest of the world. So we're having a hard time hiring enough people to do the program. There also was a time when I got here 6 years ago and I was making my rounds visiting the community. Most of the staff who did this energy assistance for them were former HHS staff, retired HHS staff. Most of them have now retired, so they lost all that, that internal program knowledge of dealing with these state systems. The state system got harder for them, so they could not get all the access they needed to do the program. So they didn't have full access. And so when you put all that together on it, it was really becoming extremely difficult for our community partner. And last year we had to come and offer them some assistance in the middle of the year to get through the energy season. And this year they came to the conclusion that the time has just really come where it is really unwieldy. And I understand this, unwieldy for a nonprofit to administer these state and federal programs that they cannot get full access to. So we have made the decision in partnership with Evelyn Charities that we're going to move this program back into HHS. We'll now be under HHS administration as of December 1st. which is when energy season begins for the low income energy assistance program. We're gonna really partner well this year to make sure that it doesn't have, that we can lessen any climate impact. So our hope is to actually take some of our staff and actually have them work at Edward Charities, so that if someone shows up there for energy, they didn't see the messaging, so they've ridden the bus, gotten off, they're sitting at Edward Charities. They don't have to say, well, you need to go back outside in the cold, get back on the bus, go over, like, we'll be able to just serve them there, our staff there. So they're working we're really working in close partnership. But I wanted you to know that that will be a priority because I've got to staff this team. So this winter, I'm basically staffing it with temps because we took it kind of quick and we're in an emergency. And not to mention, we have that little thing called Medicaid expansion coming December 1st. So we're scrambling a bit. We're gonna get through this. We're gonna do a good job. But it'll be imperative that I build what I'm calling a community assistance team next year that has adequate staffing to handle all of what I would call our community assistance programs. These are programs that you come in and get one time. This isn't like food or nutrition where you're getting it every month. This is your rental assistance. This is the mortgage assistance program we have through the county. This would be an emergency light bill. This, would be something like that you're coming one time. We're going to help you. And then you probably expect the funds that are available. Our general assistance, 200% of poverty, I can go over these programs. But we'll put them all in one team. And then we'll basically be kind of in that. Right now, we partner with all of our community assistance agencies. Now we'll be one. So like we'll be in there with them, like side by side. So I just want you to know that we must fund this team, right? Like I do not have staff to repurpose because of our food caseloads have grown enormously. And also with Medicaid expansion, we're looking at as many as 14,000 new recipients, which we're happy about. But we also have to have staff to serve. So that'll be a big priority next year. The third priority is also a contract where we have contracted for years for our visitation services for our foster children. And again, it's just timing. Our contractor is really struggling and our hours of visitation are going up. So we have to realize these are court-ordered services. This is not something I can say, we just don't have the staff to do this. Or, these are foster children visiting with parents from whom they have been removed. And our court expects us to do this. So right now, Rebecca, help me. I think we have over 240 hours a week.
260 hours, and that's just visitation. It doesn't include the transportation of the children.
Think about that. We're providing 260 hours of visitation a week. If you do the math, that's about 6.5 staff who do nothing but supervise visits. In addition to, we have to pick these children up, bring them to the visit, and take them home. So now you're easily up to 360 hours a week. Right now, my contractor is able to provide me with 2.5 staff. So back to your point, it creates yet another stress on the staff we have who are working maximum caseloads because of our current vacancy rate. And now they're having to also supervise visits, which is not a bad thing to do. They just don't have time to do it. So I'm going to suggest that we bring that back off of contract next year as well and build a social work assistance team is what we're going to call it, and hire people who can supervise visits and transport our children to necessary medical appointments. For those who don't know, there's a federal law called ESSA. So like if we remove a child must come into foster care for their safety, and they're in a certain school, but the only foster home we can find is out of district. The federal law, and Rebecca help me, requires us to transport them to their same school. So now I have to be there in the morning because there's not a bus that runs from this school district to this school district. So we have to be there, pick them up, take them to school, and bring them home because a lot of my foster parents are working foster parents. So they can't drive 20 minutes in the wrong direction to drop this child at school. So they can drive 40 minutes in that direction to go to work. So I think that I'm just showing you there's a lot of system problems. So this year, when I make my budget request, it's going to sound like a lot of positions, but all of these are core mandated services, many of which we have contracted with for years with sole source contracts. Through no fault of their own, it's no longer feasible for some nonprofits to be able to manage these services. So when I make my strong budget request this year, you guys will need to know that it's pretty stout. And again, I will probably need support because it's a lot of positions. But at the same time, I have $1 million in funding. I also have these contract funds, so I'm paying for these services. So it's really not going to be a fiscal impact that you might think. It might be relatively small there, but it is a lot of headcount. I do understand that. It's adding a lot of headcount to the county. So I just want to prepare the board. This is what I'm presenting today at 5 o'clock. This will be my budget request. And I want you to know what I'm doing before I do it.
I think this is great. So I personally think you're right. I think you're approaching this great. And all the devil is going to be in the workforce. And so are these can you give us a flavor of the wages of these jobs? Are they living wage jobs, or are they temp jobs? Are they what kind of qualifications are the bulk of the workforce you're going to be trying to hire? Because you could put in 44 positions and get 0.
Right. Absolutely.
And then you have all this work that you can't do.
Then we can't do it either. So the mobile team, and you're right, the mobile team are already working with me, so they're already here. It's 2 nurses. It's it's like a logistics person, it's an admin assistant and a supervisor. So that team is 5 people. They're already in the agency. These are living wage jobs. They're public health nurses and such. The crisis assistance team, these would mirror our current income maintenance caseworker 2. So this is like the same salary as a food nutrition worker, a Medicaid worker. So yes, those are living wage jobs. We typically we've had better success recruiting those positions than many of our neighbors because we still do pay a little bit better, and we also allow people to work from home, which is a big recruiting tool.
And the living wage in Buncombe County right now is 21,
It keeps rising.
22, 21 per hour,
21 last time.
21 per hour, right? So that's,
It was 17.
and you're able to keep up with that?
I approve all these.
Depends on the experience.
Yeah,
Some come in above that, some come in slightly below that, depending on the years of experience. It's decided by HR.
Has the county decided to raise it to 20? Has the county decided to raise it to 21? I didn't know I thought it was still 17. I just know the recent study that I read about it, I said it was 21.
Yeah. And I think that's unbenefited. I think it's 19 benefited or something like that.
he's definitely 19 or higher.
Yeah.
And then the assistance team, we're really in the process with HR of establishing what level those positions would be. So a lot of counties in North Carolina, they'll create these positions as more paraprofessional positions as like a gateway into social work. They still would pay decent, but if we make them full social work grade, they'll pay above a living wage. But we're not sure that's the best business model. They're really social work assistants, and you also build, and that way you build like a career ladder. So we have an assistant job, we have social worker 1s, social worker 2s, 3s, and then we actually have our forensic social workers, our investigators. So like it allows you to come into the system, in my opinion, and learn and grow. And these positions also would not necessarily have to have a bachelor's degree, so it opens up a pretty fair wage job for someone with an associate's degree, and also the benefits that you see in Buncombe. So we feel like it's a good model that works in other counties. And, I think too, when you move, and again, we've been able to fund this through nonprofit partners. Historically, not always, Buncombe County pays a little more than our nonprofit partners. So if an employee left there and came to work for us, they actually would increase their wages and get a pretty nice benefit.
Just wanted to summarize the segue between what I saw was a nice financial statement, which I'm learning about, and what you just said. And what it seems that 2 of the 3 priorities that you picked seem to strongly fit in with the fact that some of the expenditures for like direct assistance and social services didn't quite fit the budget. And by reworking it a little bit, it looks like you're going to be able to hit targets for the next year, whether it be for direct assistance by strengthening the energy assistance program, or in the social service department by increasing the visitation services for foster children, because like was pointed out earlier, which I was astounded because I didn't look at a lot of budgets recently, is that there seemed to have been a surplus or a windfall, or all the money wasn't spent, but with your augmentation of these departments, you're gonna hit it. You probably are aware of that, but that is, seems to be a strength that you can use for the county commissioners to show how your logic.
They do sort of, but they are parallel processes, they really are.
So does that cover studying the entire energy assistance reports?
Yes, we can mark that.
Okay, well, that segued well.
You still have her.
One nice thing I was
Very far on our agenda.
If anybody has any questions, but, and just so you know, we are planning on basing our FY 25 request on our FY 23 actuals. So that's what the county has asked us to do, so that's what we're gonna work with. Smart, we're starting. So, any questions?
Well, so that's a problem though, because the 23 actuals are way below budget. And so you're $6 million off, so you're gonna have to.
We're gonna have justifications, and there's things we brought in that we've asked for in this year.
Yeah.
So we would have a justification approved in FY 24, and that's why it's gonna be over. So we have to just basically provide documentation justification for those. So.
And you feel like you got the support that you need to, and the information you need to be able to do that?
Trying to, yeah. So I just hired, I don't know if you guys knew Esther Lale. She was our DSS finance manager. And so I've just hired her replacement, Brianna, who's currently on our team, to be her replacement. And then we'll be hiring another accounting tech. So hopefully with all of my team will be reaching out to department heads and giving this budget, getting what our needs are, and presenting that. And we want to have the tech back it up, because that's a lot of times what we need is back up our requests.
Thank you, Lee.
Thank you.
Next, Victoria, Behavioral Health Manager, will review our overdose response efforts and their behavioral health initiatives.
Thank you, everyone. I'm Victoria Reichert. I'm a licensed clinical social worker. My experience has been in child and family mental, community mental health. And so I'm excited to be here with the entire board. I've spoken some at our wellness, the wellness clinic. My role as behavioral health manager is intended to help coordinate and collaborate around behavioral health work with our various departments and programs and the community. So this was a new position funded in March in 2022. I started in March as the first behavioral health manager. So definitely a lot of work in progress and understanding. A major project has been around the use of opioid settlement funds. Okay, yes. Hold on. October 27. Okay. I think I had a worry that I had the wrong slide from a previous presentation. And so been dabbling into some more youth mental health, which I'll touch on today. And I'm glad you all have those handouts, because when I get to our youth update, would love for you all to kind of review. There's a QR code for some questions that you could provide some feedback in. And then I'm also hoping, if we have time, may share a video about some work that our health promotions did. But if we don't have time, if anyone wanted to hang out afterwards, we could play it, but it'll be on public input to share. So just to back up a little bit for those that may not be aware, there was a national settlement around opioid and the various manufacturers and distributors. Buncombe County is set to get, now I'm just blanking on the total amount, but several $1 million. So probably about a couple $1 million a year up through fiscal year 28 will reduce our amount that we're receiving, but this is all the way through 2038.
And more recently, we've done some strategic planning and also hearing from our commissioners about focusing on fatal overdose. And part of our steering committee came with these recommendations around a dual approach, where we really need to prioritize life-saving interventions, but we also need to do some work about root causes. Right now, we are focused on reducing fatal overdoses. We continue to see people dying, and a lot of individuals are being impacted in different communities that have not been as impacted in the past. And so we're wanting to really reach out to those communities, making sure that our language, our communication, our engagement is making a difference so that they understand the risks and the benefits. And so part of this work was putting together a fatal overdose emergency response team. And I'll go into detail about some of these. And some of that is also coordinating how can we expand access to medications for opioid use disorder. You may hear medication-assisted treatment or MAUD. It's a different language change, and really the intent is to say medications are necessary for life-saving measures and does not require getting treatment. While that is best practice to get treatment along with medications, it's recognizing that sometimes someone needs that immediately to prevent a fatal overdose for them to get into a space to maybe receive treatment. So changing that language just a little bit so that we're not asking someone to get into treatment, kind of like asking someone who is diabetic, start working out, start getting food, and then we'll give you medications. We want to just kind of flip that. But also we want to make sure we're giving those connections to people to get those resources that they need, that support, using peer supports, community health workers, and then most importantly, getting naloxone out in our community, and again, educating folks about the risks. They may be using drugs that they are not anticipating an opioid to be included in there. And so again, letting them know how to test, what to look for, how to respond as a community. And so this group, I won't say this is a stagnant list, but just to give you a picture of all the various programs, departments, and folks that are working on really organizing ourselves together. A lot of work has been happening in the various departments, different grants that have been funded, but really coordinating so that we are leveraging our resources to meet the needs as things change and evolve. We've been able to fund with opioid settlement funds a medical substance use professional. We have Dr. Chukin Shukla, who had worked with EMS in the Bridges to Care and Mayhead, which was allowing our community paramedics to be able to induct folks on medications for opioid use disorder in that moment. Heard stories that they were starting to do this where someone wanted those medications right then. They could have benefited from that. And unfortunately, they did use drugs and overdose right after. But now we're seeing some really good success in people getting on medications and getting connected to a treatment provider. Even in justice services, the quicker we're able to really connect with folks and support them in making those further connections in the community, we're seeing greater success and a reduction in recidivism. So one thing that has been part of this team's work is around data and how do we share information amongst our programs. We have explored considering a fatal overdose fatality review, kind of like a domestic violence fatality review. Unfortunately, we don't have some of the legislative support to be able to share data across programs. So we're continuing to explore how are we able to understand how people interact with county services, where are opportunities that we could have maybe connected that person, kind of change that trajectory. And we will continue to kind of explore what are potential legislative actions that we might want to take on a state level, but maybe on a local level that could allow us to do some deeper dive. Part of this work has been around that expanding the Bridges to Care. So at this moment, we have 4 community paramedics on shift 24/7. This went from 2 paramedics to 4. Our community paramedics were responding to overdoses, following up with community responses. At times they were having to not respond immediately to an overdose and do some follow-up, but this is allowing us to expand our reach and respond to those, again, getting in contact with folks as quickly as possible. And some important locations that we want to continue to bridge this care is with our hospital emergency department. Mission Hospital is beginning to implement a medications for opioid use disorder protocol within their emergency department. And again, finding that opportunity when they get discharged from the hospital, usually they're giving a prescription, have to go get it filled, but sometimes need that warm touch, right? Really building those relationships, having peer supports to help give them hope. And then we're also working with our detention facility. As you all may know, they have a MAT treatment program. However, there are some folks that may not be in the detention facility long enough to get inducted on medications. So we're looking at opportunities to capture those individuals that are at risk of a fatal overdose and getting them a warm handoff to someone. We're learning that a majority of releases happen between 4 p.m. and 12 p.m. at night. Typically, staff are working 8 to 5 p.m. So how do we deploy our community health work, our community peer supports to be able to be responsive and catch people in that vulnerable moment? And then we'll continue to work with our housing authority communities and child protective services and harm reduction providers. There's already some work underway with EMS, having community health workers in our housing authority communities, but just continuing to learn how to engage that community. We're also working with some of our BIPOC leaders to help design and create some additional programming that can meet the needs of our BIPOC community. And also there is work around enhancing emergency response. You may all have heard that there would be a press release today with EMS and Buncombe County Sheriff's Office around a co-responder type response. And it's just really amazing to hear some of that work when you have these different perspectives responding to 911 calls, being able to look at medically what's needed, but also understanding what's the legal ramifications. For example, someone may already have parole or have something involved with legal, and having that law enforcement lens, they were able to really kind of figure out what's the best way that we can prevent further justice involvement or further consequences. And then also connecting with the mental health clinician to get them to the right treatment, the right resource. In this one instance that I'm thinking of, this young lady was having some psychosis. Our responder team was able to really spend some time to get to know her, try to do some reach out, get information. Turns out that was not her baseline. Turns out she was septic from a UTI. And so most of the time EMS or law enforcement, right, their role is for safety. Did you break the rule, break the law? And so in this instance, this woman was not breaking the law. There was no immediate apparent safety concerns. But once we heard kind of that outcome of taking that time and getting them connected, that really would have prevented one potential loss of death, but also further justice involvement that maybe could be diverted. So excited to hear more as we continue to build that out. And part of that is looking at where can we deploy our peer support specialists and community health workers. What's our current workforce? I took a couple of quotes from our impact report to the state opioid settlement form or our settlement funds. And I think that's a big piece, is giving people hope, knowing that it is possible that they can find recovery, whatever that might look like for them. We're also exploring ways to provide some funds to address social determinants of health. Our community had some great funds to help get people access to free treatment for medications for opioid use disorder. Those funds have been exhausted, so I'm grateful that we have some dollars to help fill those prescriptions for people to continue, and as we continue to look at sustainability for people that can get access to these medications and that treatment. And then we have our naloxone distribution and community education. So there's been a lot of intentional effort to craft messaging for our different communities and cultures and language, reaching out to different media to spread the word. This is an example of a advertising for the Braille House movie house. We're targeting that 20 to 40. That's where we're seeing a significant increase in overdose deaths. Again, letting people understand what the potential risks are and what actions that they can take to be prepared to save a life. And then I wanted to segue into youth mental health, and I shared in your handouts, this is not the complete Photo Boys project, but North Carolina Healthy Transitions had worked with some youth in doing some photos and talking about what mental health meant to them. We were able to host this at the HHS building in September, having different resource providers to share about opportunities to support youth. And there were some really neat insights that these youth came with. And so on that last section, there is a website, NC Healthy Transition. I encourage you all to check it out, see where the display will be. They do have the photos and the quotes on their website. And it was really neat to hear some of that feedback from our youth about what they need. You know, nature was a theme that came out, and also youth having safe spaces, places where they can talk about their thoughts, their feelings, what life is, you know, how life is going, being supported. And so it was really neat to see that work, and we're continuing to make some plans around youth mental health and how we can intervene. One, I wanted to point out that our health promotions program has supported some programs recently to help with youth mental health, some parents and youth in Spanish, and also some connection and resiliency work in nature. And so these next document that's in y'all's handouts, our AmeriCorps fellow, Eva Davis, who wasn't able to join us today, but she's been starting to do kind of a current state analysis of the resources that are available. What are those opportunities? And I think one thing that we've all acknowledged is there are lots of resources. How do we really communicate that to our communities so they know how to access that? What are those programs that are making a difference? How do we expand the reach? And so these were just some initial research that she had done and some programming. And on that last page, there is a QR code, also a website that can give you a space to, if you see a program on there that you know of that's missing, sometimes if you can't Google it, right, you don't know it's out there. And so letting us know what are those resources that you think are available or that we should pay attention to. I think there's, she was looking at this, there's opportunities with teen mental health first aid. We're hearing our youth want our adults to be more informed about how to communicate about mental health. How can peers help one another? And so I know there's been lots of effort around youth mental health first aid, but what if we look at teen mental health first aid? How can we continue to educate our community to talk about mental health? Our youth do have opportunities. I recently had heard a story where another youth talked to a counselor about a young person that was self-harming and being able to coordinate with another school to then really wrap this young youth around to make sure that they had that support that they're needed. And so we just want to continue that work. So we'd love to get y'all's feedback. I know we're getting a little close on time. What do you all think? If I should share the video or maybe leave that at the end or leave it for later? I mean, to look at it when you can. Okay. It'll be on the public input page for this visit, that video. It is just, I mean, if you want to have a feel-good moment on a Friday, watch this video. It's less than 8 minutes. You're really hearing some of these youth and their participation out in nature. I love this one young lady. She was like, creeks, outdoors, not my jam. But I got in the river once, got in it again, it felt better. And so what I took away from that is experiencing something new. And what will that help our young person in the future when they might be afraid to say, try something new, and they can think back on this day, a fellowship with other peers and positive adults. And they were able to find they could do something new and different and get a really good experience. And so again, I just encourage you all to take a look at it and enjoy a Friday video with uplifting messaging. Any questions?
Can we watch it at the end?
We could,
know,
yeah,
for-
anyone that
if
wants to
somebody-
hang out.
Okay.
Yep, have to do that. Yes, please.
I just want to make a plea for metrics. Especially if you have to go to a commission, other individuals, because bringing up the relationship between opioid use disorder and mental health, and you're bringing up programs and you're bringing up interventions, and you brought and you did have on the written things you passed out a couple of data points But my plea is for metrics, because I think that as an advocacy group, we like to see how everything works in order to make decisions, because everything you say about programs and interventions in the future or in present sound great. But I think it's important to understand, how they work, how they can be budgeted, kind of the hard decisions you're gonna make.
And that is something that I think even as a group, we're really working on. What's that data available? How do we even understand people who are involved in one program and comparing it to public data, like such as bookings? And what does that story really tell? So that's definitely something that we're diving in deeper to make sure that we have that data to tell that full story. And that we're also withholding, following the privacy and confidentiality between programs. But that is kind of our main focus right now, is to really have some robust data to share and to make informed decisions. So thank you.
Just as another little informational point, our neighbor county to the south, Henderson, is actually doing quite a big initiative with the school system with Advent Health and the faith community in developing some systems. And so I just wanted to make sure that they were having some challenge in getting partnerships from Buncombe County. And it doesn't make much sense to me that Buncombe County and Henderson County should be working together. I mean, when we looked at the rash of suicide deaths in youth, it was both Henderson County and Buncombe County, and it was more rural. It was the county, not necessarily others, So I just want to make sure that we're being collaborative. And I do believe now, David Thompson is now engaging with that. And I don't know, I still don't quite understand sometimes our role in the health Department of Health and the school, the county versus the city, and how that all works, and how we collaborate in leadership, what your relationship is with the superintendent and things like that. And it seems like we have opportunity for improvements.
Ask a question. I want to say a show of hands of everyone in the room who has access to a dose of Narcan. And for those who don't have it, do you know where to get it?
No.
Yeah. So, that's. Yeah. How would you advise keeping the sport to where how to get those Narcan? Because when you're out on the street and you're downtown Asheville, what have you, I've come across 2 instances where someone was laying on the sidewalk, should be laying on the sidewalk, right?
So we have a couple syringe service programs within the county. One is at 40 Cox, actually just across the hallway. It is Monday through Friday from 12 to 4, and anyone can come in. And it does sound like we're seeing a change in people who are showing up to syringe service programs, perhaps the weekend warriors that are wanting to go to a show, maybe take some drugs recreationally, and they are showing up to that syringe program to get some harm reduction, some naloxone. There is also WindCap on Fairview. They have supplies as well. Again, providing some education. We also have Steady Collective. They are out in the community in different neighborhoods that they would be also able to supply. And then lastly, if that wasn't something that someone felt comfortable to just go to a syringe service program, which again, there really takes some steps for privacy and confidentiality, but our Health Promotions is providing a monthly free training to the community on the first Friday of every month at noon. And that is right at our entrance to the HHS. So you're welcome to come, and in there, it is about an hour training, talking about the risks, the resources available, about our community paramedicine, how to respond to naloxone, what are treatment options. So more than just handing out the supply, but really educating about how to respond and what those resources are. That's great question to have.
Well, and isn't it true that anybody can walk up to a pharmacy and purchase naloxone for their own benefit without prescription?
That is a good point. Yeah. So for those that do have,
we could all just have a dose of naloxone available to us in our car, in our handbag,
Yeah, and actually recently our libraries have installed an Alox box, so a box that's out in the open. And it was shortly after it was installed that Narcan was used to reverse someone in our library bathroom. And so I think, as you're saying, it really can happen anywhere, anytime, and to anyone. And that's, I think, that messaging we're trying to do. And I think, Dr. Fran, it's important to note that those that are able to, because the cost, I think, has maybe reduced now. It's about $40 a kit. With it now becoming over the counter, it's reduced by a couple, $10 maybe. Yes.
Pharmacist.
Yeah, good.
Over the counter, it's still pretty close to 40.
Okay.
But we can still bill through insurance on a protocol. So it's totally fine for you to ask your pharmacy team to see if it's, because we have still seen it be covered for free on insurance. So it's fair to ask, but you have the option either way.
And just to be clear, you don't have to be an opioid use disorder person to get the naloxone. We can
No.
carry it like an emergency in our emergency bag to help somebody else.
Right. And we get requests all the time from like hotels, people going to concerts, anything like that. They just want to have it.
Yeah.
Well,
Thank you,
Ron.
Victoria.
Appreciate it.
Appreciate it.
Thank you.
Next agenda item, Jennifer, with adult services, going to review the adult placement weakness policy.
Hey, good afternoon.
Good afternoon.
Hi. I'm Jen Teague. I'm the program manager of Aging and Adult Services with Buncombe County. I believe you all have the waitlist policy in front of you that we're asking for your approval on. Last month, I gave an update about where we are with adult aging services and also just briefly shared about placement. So a quick update as to why I'm here asking for this. It's actually in policy that for a waitlist to be created, the HHS board has. We really don't have a wait list on any other service area in adult aging services. The only other thing that would be close to that would be our in-home aid program. And it allows for an inquiry list without approval of the HHS board. So placement is the only program that requires that. The rest of our programs are mandated and you have to add people into service as quickly as we receive the reports or within timeframes that are allocated. So what you have in front of you is our recommendation for the placement waitlist policy. Essentially, we are asking that we open no more than 3 cases at any given time, and then any other one will be prioritized based on the language of the policy, which you see there listed as A, B, C, and D. And as individuals roll off or we get them placed, we'll then put the next person into service. Part of the reason that you're seeing this come today versus like years ago, you may wonder, why are we talking about it now? We've continued to see an increase in our numbers in adult and aging services and other program areas. Special assistance, for example, is one area where we've seen a growth in numbers. We've also taken the foster care 18 to 21 program into adult services. And so we've actually moved our placement work from our social worker 2s to our adult home specialists, and they have already, they already have other additional tasks on their plates. So they are now also taking on placement, and we have 3 workers really doing the placement work. And so we feel like each of them can manage 1 additional case at a time on top of the other work that they have, and then create the wait list. Happy to answer any questions.
So it sounds like this is a problem of staffing. Are we gonna solve the problem with staffing? Do we have to do this? And then once we have the staffing, help me understand this strategy. It seems like I'd rather focus on the staffing than create new policies of waitlists and things like that.
We could, yes, we could staff our way out of it. We don't currently, to my knowledge, have any additional staff being requested for adult and aging services. We have grown in adult and aging services with staff, so I very much appreciate Stoney and this board and Rebecca's advocacy over the past couple of years to continue to grow adult services. But again, our growth has also brought in additional numbers and requests.
Well, today is the day to request new staff. Correct? Right? I mean, is that what, so help me understand, why aren't we doing that? Why aren't we requesting more staff in the 2025 budget for this service?
A little bit more about like how to interact with myself. This is a service that is incredibly important. Useful is to say it's a service that's something that is public. So it's and we do it, sometimes we do it through other services. So like, you know, like if a person's if we have an adult protective services case, we have an adult who's been found incompetent by the court, and part of their issue is they're living in a really difficult situation, they're not receiving adequate care, they're not able to care for themselves. Well, then in essence, we would do placement services as a part of that adult protective services case. So Joe, would you describe like what this would look like in real, like that person who came and asked for it?
Yeah. So in adult aging services, we have about 13 different program areas. And so one of them is the APS process. So when we get a report, we do an evaluation. If we substantiated a need such as placement, we open that under what we call planning and mobilization. So that work would not be impacted by the policy you see in front of you. That is a mandated service, APS. We have to go out, evaluate, make case decision, and then offer services for protection. This is a different service that adult aging services offers called placement that is still required, but it's like a lot more fluid in policy around what you can do with it. And so the extent to what counties do is very different. Some counties just hand people a packet of resources and say, here you go out and try to find a place for a placement. We tend to take a little bit more of an active approach in assisting people in trying to find placement. You will also see that we do not define placement as independent living. So that is not what this program is really for. It's about facility-based placement. And so it's really for individuals who do not meet the threshold for adult protective service criteria. So they are not eligible, they're not either functionally disabled, they're not being neglected or exploited, or they're not in need of protection. They're truly just an individual or a family member who's looking for long-term care placement or assisted living placement for their loved one. And so they will call us or call the office and make a referral. Sometimes it's easy things like I need to start the Medicaid process and they don't understand. Other times it's the true, I don't even have transportation to get to a facility. I don't know where to start. And our social workers are driving them. They're picking them up at their home, they're driving them, and then FL2 requirements to go into placement. It's not just, oh, we found you a place. FL2, it's TB tests, COVID testing. It's medical records so that facilities are reviewing them. It's an extensive process. It's helping people understand the financial ramifications of placement or getting them approved for those services. So that's why it's unfortunately not just as easy as here's a referral and here's a list. I think that does happen in some counties, but our process has been much more extensive, which creates a backlog as we are adding additional work onto staff.
Yeah, so I appreciate that. So what you're saying is that this is not going to be for the people who are currently in crisis. However, we all know that the only way that the average person can actually navigate the system and get in is to go to the hospital. So then you get 3-night stays, and then you will qualify, and then you will get assistance to get placed. And so that's the way people have to navigate the system. If you don't go to the hospital, if you're not sick enough to go to the hospital, it is almost impossible for an individual to get into a nursing home without assistance. And that means the family is stressed and the doctors are stressed and everybody is stressed. So this is a really valuable service that is needed for folks. And so if it's not mandated, I understand you have to choose where you're putting your money. And so it's not the at-risk in crisis. So that's, where those people are taken care of. We're not leaving people hanging that are being abused or neglected or disabled or like they're. So I appreciate the fact that we can make some choices for them, but still, this is a really important service.
It's a huge thing in our community, but I can tell you the times I just had reach out to me personally to help them through the placement process.
It is really hard.
Friends, it's a very difficult system to navigate. Jen, are there any of our nonprofit partners also providing the service from a community perspective?
Not really. You're correct about rehab days if you're in the hospital and then they assist with the placement. We do sometimes get referrals from the hospital. However, if individuals are difficult to place. I also want to say, I don't anticipate this to be creating a long wait list. Like we're talking a couple individuals at a time, but right now I have no options because the policy requires that we have to have HHS board approval for a wait list at all. So what I have right now is I have a supervisor that's actually managing cases while she's also got 6 staff. So if we can have at least a little bit of breathing room for whenever the cases are coming in. We are still assisting, like we're still contacting the families, we're still providing resources on the front end, but we're just letting them know, or what we will do is we will let them know it may be a couple of weeks before we can get to. But here are some resources that you can utilize until we get to that place. And again, I do want to just reiterate, because I want everyone to be really clear that like this is not impactful to our APS work. Our mandated APS work will continue just as it does, and if placement is a need identified in that they will not be waitlisted. We will continue to provide that service.
Do you have challenges finding a facility that has openings, or is that pretty easy? I know the workforce issue has been challenging in our facilities in recent years.
That's an excellent question, and it is very hard to find placement. We are not the only county that's struggling with that, whether that's through our APS process or our placement program. We have actually had about 30 facilities in our community close here in Buncombe County over the last 3 to 4 years. So that's impactful in what options are available to individuals. We are fortunate that we have some really great staff who have built some really great relationships, and so they pull on those relationships whenever they've identified a need. But yes, finding appropriate placements continues to be an issue.
We have been really intentional over the last 5 years, I guess, to build our team in adult and build our influence in the community. So we saw this 5 years ago as an area where our service array did not seem to match our population. So we haven't slowly built our adult, like we have an aging coordinator now, we have more staff, but it does continue to grow. To be honest, when I look at my populations that I'm mandated to serve, the aging population, you wouldn't have to be aging to be placed, but primarily we're probably talking about 60. As we continue to grow that, we continue to craft what to like. This year we got into MMA, like we weren't really managing MMA, now we are. And a lot of this really is to Jen, Greg's leadership, but we have been building an aging service continuing Buncombe County. You don't have an aging department, so we're assuming that role at the HHS. And I will say it's kind of a slow build because of competing interests, but if this board were to direct me to ask for a social worker to do placement services, I would be more than happy to do so. I just knowing the reality of the overall build. Not sure it's the year. And if folks weren't getting served, I would definitely, there just have to wait a couple of weeks. And it's not good, but you're my director, so I guess we could do that.
So will you be able to report back to us on if you start seeing a waiting list? That, I mean, the one that concerns me here is that if you remain on the wait list for 1 year or more, nobody's going to be able to do that. You know, so can we get some, after you implement this wait list, can we get a follow-up of saying, hey, this is what the average time on the wait list is? If it's 2 weeks, great. If it ends up being 6 months, we got a problem. And it'd be nice for us to get a little feedback about that.
Yes, I'm happy to do that. I'll be happy to do that.
Are there any more questions before we take a vote? Well, if not, do I have a motion to accept the waiting list? Leanne, thank you. Second.
I'll second.
Thank you, Stan. All for, say aye, raise your hand, any opposed? Thank you.
Thank you.
There is no new business on, under director's report, calendar update.
Yes, and then just quickly, just update the board, just so you can get up. So next month's meeting will be a week early because of Thanksgiving holidays, so we on November 17th instead of the fourth Thursday in December. We talked about it this last board meeting, and Zach has talked about it. So we actually are going to cancel our December meeting in terms of a formal business meeting. And instead, we're going to have a board luncheon, a board holiday luncheon on that same day, December the 15th at noon. Details will be coming out, but we will conduct no formal business. We just want to serve you a nice meal and thank you for your service to our community. It will just be a chance for us to fellowship and together. So we'll meet in December, but not for a formal board meeting. And then Krista's working to put together a calendar for next year, which she can send out to you. So you can plan on have every board meeting date for the calendar year, which ones are virtual, which ones are in person. So we'll have that. So just wanted to update your calendar.
Mark your calendars, third Friday. in December.
And one of the things that just came up, we are hoping, we're working with the County Commissioners Association to host a documentary of a veterans film about the impact, the life and the day of a veteran in North Carolina. It also highlights local veteran services offices. So this board does not agree, either HHS or the board. I would like to see you be the executive sponsor of this public screening, and then staff, probably our VSO office, will be the host of the event. And we work in conjunction with the County Commissioners Association. This just came up. And we were going to do that the week of November 13th through 17th, somewhere close to Veterans Day. If the board has any issues with that, we back off, but we thought it was a really nice opportunity since we are the correctional services agency. From a county perspective, it's rather large, and TCM's got a lot of partners we think will come to this screen.
And I can see recordings, right? Kelly, okay. All right, well, in order to adjourn, do I have a motion? Second? And all in favor? You good at this?